there is decreased renal insulin clearance, decreased clearance of oral drugs also, and decreased food intake. So that may cause hypoglycemia. And hemodialysis actually decreases the insulin requirement due to decreased glucose clearance. And peritoneal dialysis, that may increase the insulin requirement on the other hand, because if the glucose containing dialyzer is used, and otherwise not. And intraperitoneal insulin is more physiological, more convenient. Of course, it is more costly at there. And this another case here, a 52-year-old male, type 2 diabetes mellitus for 12 years on insulin. This patient, he is a PhD, and I have seen this patient in my MD's chamber. I have seen him several times. He was on insulin and on bilirubin, and he monitors blood glucose regularly. And this was actually his blood sugar level. Morning time, it is well controlled. Post lunch, PPBG in the lab record, it is well controlled. But the creatinine, it increases. And he had one episode of hypoglycemia in the 3A. And actually, this is one record, but he had several episodes. So, what is the cause behind it? When I took the history actually, okay, I'm coming later, I'm describing the case 7 because these are almost similar. She is a 47-year-old housewife on premixed insulin and good control. Hypoglycemia at midnight on 13th and 14th February, the dose adjusted, and 1 month later, actually the 4 units night dose of insulin was decreased because she had hypoglycemia at the night, but 1 month later there is rising blood sugar level. This is very commonly we face. We decrease the dose and there is increased blood sugar. We again increase, again there is fall of blood sugar. So this is very common. So what to do next? So these cases compared. First one, increased pre-dinner blood glucose, occasional nocturnal hypoglycemia and fasting peak blood sugar control. The second case, 2 isolated nocturnal hypoglycemia and dose reduction raises blood glucose. What happened to the first case? Actually, his office hours was up to 6 or 6:30, and when he comes back home at 7, he takes a heavy snacks. He takes some. He told that he takes actually upma or something like that, very heavy. Sometimes he takes 2 chapatis. And what is actually his pre-dinner at night? It is actually his postprandial blood sugar. So, and that's why he is taking heavy snacks in the evening. He is taking very little dinner, very little food at dinner time. So, what happens? That this heavy evening snack and light dinner, it will cause this high pre-dinner blood sugar level with this low nocturnal hypoglycemia. So, these things are very important to concern because we have less time. We can't interact with the patients. And the second case, actually, the patient had skipped meal following altercation with husband. She actually missed his 2 meals, and so there was hypoglycemia, and we actually adjusted the dose. So these 2 cases, another paired cases. A 49-year-old female, she had well-controlled diabetes, and she had actually in the month of October, 25th October. This date is very important here. There is a clue in the date. Here there is deterioration of blood sugar control 201 and 278, and the same type of blood sugar level in a 56-year-old male. Same rate. Well-controlled diabetes, suddenly such a high blood sugar level. So what is the cause behind it? Yes. Durga Puja for the first patient. The patient didn't bother to take her medicine because she was busy in roaming here and there, and also the diet was not that much because she was not concerned about her diet at that time. And the second patient is a Muslim patient. Actually, the Ramadan month, it also comes simultaneously. So what happened? He fasted and he didn't take his medicine. So these things are very important. And festivals can change lifestyle and worsen glycemic status. Now, there are some recommendations for management of diabetes during Ramadan month. There may be complications. It is a double-edged sword. Because of fasting, there may be hypoglycemia, and because of very heavy evening dinner or evening snacks, there may be hyperglycemia, decay, dehydration, thrombosis, etc. due to this fasting. And there are certain recommendations in Diabetes Care 2005 that balanced diet should be taken, exercise with caution because of this fasting, change of timing should be there. Sensitizers may be used because they don't cause hypoglycemia, that should be counseled to the patient. Meglitine is preferred than sulfonylureas because meglitine has a short onset and offset of action. So before this heavy dinner at evening time, they can take meglitine and that will the action will wane off later. And same is true for basal insulin. Before sunset or pre-dawn, they can take basal insulin. That will maintain the fasting blood sugar level at least. And rapid acting is always better than short acting. And break the fast. This is not breakfast. It is break the fast if there is hypoglycemia. But this is actually, Islam is a very widespread religion. So these recommendations have been made in diabetes care. But the same principle is true for our Chhat Puja or Ninshashti or like those festivals. Now she is an 8-year-old girl, type 1 diabetes. For type 1 diabetes, this age group we don't go for any very strict control. We are very happy with 8% HbA1c, and the patient had that. One post-lunch was even 220, not very low, very tight blood sugar control. But the patient fainted in the playground once. What was the cause behind it? Actually, one teacher was absent on that day, and unexpected play hour before lunch as the teacher was on leave. So the girl played for another period. She was taking insulin, so there was hypoglycemia. Although she was not even near about hypoglycemia in her previous episodes. So exercise and diabetes next comes. So exercise and diabetes, again a double-edged sword. It can cause hypoglycemia, can cause hyperglycemia and decay. Hypoglycemia is due to increased skeletal muscle blood flow, and so there is increased insulin absorption and also increased blood food uptake. And hyperglycemia and decay is due to, during exercise there is increased secretion of cortisol and adrenaline and all these things. So increased counter-regulatory hormones in this patient, if they are in poor control, that may produce hyperglycemia and decay. And also HOMC is not very much applicable to younger patients who perform exercise. This is another case, 32-year-old female. This is very, very common. I have seen hundreds of these types of cases in our female medical ward. This one day it is 89, next day 255, next day this one, even one hypoglycemia. It is erratic blood sugar level which we can't explain. So what is the cause behind it? It is well controlled, next day it was high. So the insulin dose was adjusted, later hypoglycemia, again dose adjusted. And this erratic level, actually what happened, one day nursing staff is given, one day the in-charge sister, one day the training sister. So insulin injection technique, it's very important. Wrong site and wrong technique, that may cause this alteration of glycemic status, and we don't take the history whether the insulin has been taken in a proper way or not, and we just adjust the dose, so there is erratic blood sugar level. So these are the typical insulin injection sites. I think everybody in the audience know this. This around umbilicus and this lateral side of the thigh, upper arm, etc. And this is the proper technique. Pull the skin with subcutaneous fat and then straightway at 90 degree give the insulin. Now this case, this is also very interesting. 9-year-old male patient with 25-year duration of diabetes, twice daily premixed insulin, had abdominal distension, recurrent vomiting and dizziness for 3 months, and hypoglycemic episodes at midnight, at 2 to 3 am and also 4 to 5 am. Fasting blood sugar level is normal and creatinine is 1.2, not like that due to renal failure he will have hypoglycemia. So what are the causes? Here is the clue: abdominal distension, recurrent vomiting and dizziness. This is actually postural dizziness. So this is the sugar level. You can see the post-lunch there is hypoglycemia, pre-dinner there is again hyperglycemia, and this patient does not take heavy snacks in the evening like that PH80 of course. This is a separate history, and there is 2 episodes of hypoglycemia at 3 am. So what is the point here? I have stressed on this, emphasized on this. This is actually a case of gastroparesis, so autonomic neuropathy. So what happened with this autonomic neuropathy? That will cause early postprandial hypoglycemia because there is delay in gastric emptying. So when the insulin is acting in its peak phase, then actually the blood sugar absorption of this glucose has not occurred. So there is postprandial hypoglycemia. And when there is insulin acts, actually when the action of the insulin wears off, that time there is hyperglycemia. So there is a mismatch between the high insulin level and the high glucose level. So late postprandial hyperglycemia in long-standing cases of diabetes. Here is a 55-year-old male. You can see here the dates are very important. You may look at the dates. 24th December, there was a hypoglycemia at post-dinner. And more or less controlled, again another hypoglycemia at 47, at level of 47, and this time the patient landed up in coma. He was unconscious. So what was the cause behind it? It was alcohol. So he was in the bed, in the 31st week, he took so much that actually he get comatose. So this is very important, particularly in well-controlled diabetes. If the diabetes is not well controlled, then it is okay. But if the patient takes binge and doesn't take dinner that much, well controlled